patient with pain here would be, once again, substernal, maybe pressure sensation. That's how they would describe it if they were to feel the pain. Why do I say if? Because can you have a patient who has a silent MI? Of course. What may happen then? Or how did that occur? It's the fact that the nerves have been shot. Maybe there was diabetes mellitus resulting in diabetic neuropathy. And so at that point, the nerves are not able to properly feel the pain, and that's very scary. And you know for a fact the patient with diabetic has what? Increased VLDL, which contains triglyceride. And this may then accumulate in your blood vessels. The pain, how long does it last? Approximately 20 minutes to hours, but it's not a fleeting pain, huh? Versus what? Versus your anginas. Remember in exertional, it was exactly that, exertional, stable. Unstable, maybe about 30 minutes, even at rest. But eventually, remember, that is not an MI. This is. So we find cardiac enzymes. It radiates the neck, jaw, and arm, and associated with diaphoresis, right? Physical examination, your sympathetic activity has kicked in. Once again, if your heart is beginning to die, you decrease your cardiac output because you refer to this as being what? Cardiogenic shock, huh? If there's cardiogenic shock, then what branch of the autonomic nervous system is going to be stimulated? The sympathetic nervous system. If it's a sympathetic nervous system, it's doing everything in its power to restore heart function, isn't it? It may then function on your beta-1 receptors excessively, resulting in tachycardia. Now, if there is enough damage taking place with the heart, at some point, the left ventricle becomes large. Pay attention here, please. So now, the left ventricle becomes enlarged. Association with CHF, congestive heart failure, from AMI, acute myocardial infarction. Whenever there is congestive heart failure, well, I want you to think about the heart sounds that we will discuss. And when we do in great detail, then you know that S1 is the closure. Closure of what? Closure of a mitral and tricuspid in that order. S2 is the closure of what? Closure of aortic pulmonic in that order. And when does your aortic valve close? I want you to pay attention aortic valve right now, specifically. It closes during diastole, doesn't it? Yes, it does. If it closes during diastole, then what then opens? Mitral valve. Are you with me? If you don't, make sure that your physio is strong here. It's the only way that you're able to properly understand this, and this information will never leave you because it is a permanent part of your heart and brain and soul. So now the mitral valve opens, and this left ventricle is rather large. And all of a sudden, this blood is rushing into left ventricle. Are you here? Stay with me. The blood is rushing into left ventricle. Are you going to create a heart sound? Of course you are. What's this called? S3 gallop. Are you with me? And that's what S3 is. It comes after S2. S2 is a diastolic type of heart sound because that's the only time that you have aortic pulmonic valve closure. Subsequently thereafter, the mitral valve is then going to open during diastole. And if you have a large left ventricle, you're going to create an S3. Pulmonary rails may be present. Why is that? Well, let's go backwards. What do you mean backwards? I mean to say that, well, earlier we just talked about S3. And if the heart's not able to move forward because of acute myocardial infarction, then perhaps there might be congestion. If there's congestion taking place from the left ventricle, then you're going to back up into where? Good. Left atrium. After that, what are you going to back up into? The pulmonary veins. And then where are you going to back up into? Increased hydrostatic pressure in the pulmonary capillaries may result in pulmonary rales. A new systolic murmur due to papillary muscle rupture. Is it a complication that could occur? Of course. Worst case scenario, what if there is a ventricular rupture, huh? It may result in something like a VSD, perhaps. And when you have that type of rupture, my goodness, you're worried about things like cardiac tamponade, especially if it's a ventricular wall rupture. Huh? So that rupture, be careful, please. This is ventricular septal, and here we're looking at physical findings of new systolic murmurs. You should know already that VSD is a systolic murmur. On EKG. Okay, now here, let's put things together. I have repeated this. I've introduced this already to you, but let's just make sure that we're clear about what kind of EKG changes you expected to see. Please focus upon transmural MI. We have a peaked hyperacute T wave. Next, ST elevation. Now that, by far, is the most important point. The ST elevation is found with transmural. And once again, you tell me what kind of coronary blood vessel, an artery or an arteriole? You answered that question? Artery, right? And if you have that picture anatomically, once again, you will remember that as soon as the artery has been occluded, there's complete draping of infarction over the entire transmural issue. We have something called Q waves, and I'm not going to focus upon that so much, but it's the fact that normally the Q wave, at least tell me this. What is a Q wave? Is it a negative or positive deflection? It's a negative deflection. It's the first negative deflection that you would find normally in EKG. If you find that Q wave to be exaggerated in terms of its negativity, that is referred to as being a Q wave. Just keep that in mind. It doesn't mean that it's absent. It just means that it might be exaggerated, especially if it's a chronic type of MI. Let's continue. ST segment evaluation is a classic infarction pattern, and this is what you pay attention to. If it's greater than 1 millimeter, which is one box, remember dissecting an EKG and what a box means to you? So that one box greater than 1 millimeter or two in more contiguous leads, by definition. And ST elevation. What about the EKG and its T waves? Now, it could be peaked or it could be inverted. The development of new T waves then indicates a transmural MI. And what that means is that they're usually part of late finding an AMI. Your focus right now should be on ST elevation. Once you've understood that, you've got that firmly embedded, then you move on to take a look at these other waves that are relevant when dealing with acute myocardial infarction, transmural type. MI here, new conduction system abnormalities, and that we already know. And whenever there's a myocardial infarction, my goodness, you are now compromising the conduction system, so therefore you're introducing what? New types of arrhythmia. There might be a new left bundle branch block. Now, how would you know that on your exam? What would they give you? A left bundle branch block. Now, close your eyes and think of the following. We have bundle branches. So you have just moved from your AV node through the bundle of his, and you're moving through your interventricular septum. Are you not? Are you there? Good. Now, you have a left bundle branch and a right bundle branch, normally. Now, you tell me, what is it that permits the aortic valve to close? Don't you need a depolarization event? And so, therefore, the left bundle branch is going to depolarize first, always, physiologically. So the aortic valve closes, and then followed by the right bundle branch and the pulmonic valve. Is that clear? We have A2P2, A2P2, A2P2. Collectively, what heart sound, please? Second heart sound. Good. Now, what if there is a left bundle branch block? What happens? It means that you have decreased conduction through the left bundle branch? Yes. So does that mean that you have conduction passing through the right bundle branch? That's exactly right. So that results in what kind of split? Paradoxical split. Excellent. Okay. EKG changes. Maybe there's a left bundle branch block resulting in a paradoxical split of your second heart sound.